So this will be our topic today. Want to give some disclaimers here. A lot of this work is drawing from the work of the North Carolina Research Center, which is funded by HRSA. And so, of course, this is our info and opinion, not theirs. We have no financial conflicts to report. For the most part, we'll start with national and rural and southern perspectives and kind of do different concentric circles to give that perspective. And probably one of the bigger ones is particularly those with finance expertise here are these data that both of us are working off of are largely from the Medicare cost report. These have limitations as opposed to an audited financial statement, but are probably pretty good and may differ slightly from specifics. So a general outline of how we expect to spend the next little less than an hour. I'll talk a little bit about recent trends and where we're going. George will talk about the rural emergency hospital, and then we have a little bit of time for Q&A at the end for any discussion on that. So if you want to reheat your lunch during part one, the one slide summary review of the next 15 minutes is that we'll talk a little bit about what's going on recently in rural hospital finance and through the last pandemic, and talk a little bit about the difference between the two. In some measures, it looks like hospitals are having tremendous last couple of years, but that's a virtual and a false impression in many respects. We'll talk about pivoting to outpatient focused facilities, particularly in rural, away from an inpatient, which is sort of a little bit different from the way that many of us think of as a hospital. And then real briefly about mergers that are happening. So there have been some different published media reports typically that use a phrase like record profits that hospitals have had during the pandemic. And there was like I said, there's been a couple reports that you can find without too much Googling that shows us, especially about last year, that just seems to suggest that hospitals are doing amazingly well during this pandemic. One thing that it's really important to think about is to separate total margin from operating margin. And then one study cited there looked at the two. And if you think about sort of like how CARES money was deployed, the analogy I use is that when my son in the summer and he works as a lifeguard, he's got money coming over hand over fist, which can afford a lot of Bojangles. But in February, when he's not working as a lifeguard, he can't afford that Bojangles, but yet he's able to keep going because we give him the subsidies. And so in February, he's still eating a Bojangles. It looks good, but if you're not careful in acknowledging that subsidy is the only thing that keeps him going there. And so how we count the CARES money and how it's allocated in the financial statements can make a huge difference in how things appear. So I'm going to denote patient margin here as patient revenue only, and separating a little bit from the notion of operating margin. And so we think of this as a moving average since 2011 of the roughly 5,000 hospitals across the country. The orange sort of EKG line is the total margin. So is that the average hospital is making somewhere between 3% and 6%. The green is the patient margin, or the patient margin. So the average hospital is losing a little bit of money on their patient operations. Now you'll see there are two red lines there. One of them is March 1st, 2020, which is by some measures the start of when the pandemic really started taking off. The second line is 1 year after that. So this window here captures what happened for hospitals reporting in the first year of the pandemic. And you can see this is largely, I think, what most people expect. Patient margin cratered, saw huge declines in this and huge losses on the patient margin. I was gardening in April 2020, did something stupid with a shovel and should have gone to the ED, but have a scar on my foot from my treating it myself, which will be a constant reminder of that. And that's what happened in lots of places, right? People really avoided getting healthcare in that period. Margin took a big hit. But look at the orange, which is the total margin. That increased pretty dramatically, and that's because of the CARES money and the federal supports that stepped in to help keep hospitals afloat during this period. Since then, we've seen patient margin return to its pre-pandemic levels largely. Total margin is still high, but continues to float down. So this is sort of where we're at today, and that depending on which margin you look at, if you're looking at the orange, you're still saying hospitals are making profits that they have not seen in the last 10 years. And that's because of this CARES money that was used to support them during the February I'm not a lifeguard time. Same graph, but for rural hospitals in the South. And you see generally the same, similar patterns, relatively, not much trend in the orange or the green, maybe a little bit of a downward drift in the last 8 years. Patient margin falls and returns, orange climbs up and largely sits there. But what's interesting is if you overlay this one with the all of them, it's a busy graph, but the thick lines represent rural southern hospitals, whereas the thin lines are national. And let's look at the green lines first. You see that largely the patient margins are about equally apart throughout the entire period. Maybe they get a little closer during the pandemic, but are pretty much equidistant, 5 to 7 percentage points difference between the two, with rural southern hospitals having lower patient margin, averaging there in maybe the 7 or 8% loss. Now look at the oranges. And what's interesting here is that, again, similar up to the beginning of the pandemic, these are largely tracking together. But during the pandemic, we see larger gains in total margin for rural southern hospitals. And so that now basically they've almost aligned, still a little bit higher nationally than rural South, but they're much more similar there, whereas you still have that gap in the patient margin. So why is that? Well, when the CARES monies was being designed and the different pots of subsidy were developed, there was a recognition that rural hospitals had those lower margins from the beginning, would be almost certainly in a weaker position to weather the storm that we knew would be coming from the pandemic. And so if you look on the far right of this table, the percent of 2018 operating expenses that were provided in CARES funds was double for the average rural hospital than it was for urban. And so that's why we see that narrowing of those margins there. Here's the same data presented in a slightly different view, where it really underscores the difference between rural, which is the panel on the left, and urban hospitals, the panel on the right. You can see, again, the big difference between each year from rural to urban if you compare the green total for 2016 for rural to urban of 2.1 to 5.7. But what's interesting here is a similar type of thing. Look at 2019 to compared to 2020. If you look at the urban side first, the greens basically stay the same. Those are total margin. The oranges stay the same, which is basically operating margin, which includes some government supports. But the patient care fell from 19 to 20, as you would expect. But contrast that with what happened in rural, where you're seeing the greens and the oranges increase. So this really provides evidence of that larger care support for rural hospitals because there's recognition of them being more fragile from the beginning. And so now if you look in 2021 data, rural hospitals actually have a higher margin than urban from the total and operating, which has never happened in the 15 years, 20 years that George and I have been hanging out together. Before I get a little bit more into closures, we need to recognize that there are huge equity issues when we're talking about rural hospital closures. And so if you think of a hospital on the path to closure as multiple joints, I guess these would be called in a plumbing parlance, hospitals are more likely to be hospitals that are in communities that serve African-American populations are more likely to be financially distressed. Among those that are distressed, those serving Black and or Hispanic patients are more likely to close. And among those that close, those serving markets serving more Black populations are more likely to cease all healthcare services. So at every step on that pipe, Black populations and to one of them, Hispanic populations are more likely to see a decline in access. I want to shout out one of our current PhD students, Sharita Thomas, who's done most of the work in this area. But it's an important finding to really recognize that these rural hospital financial challenges have equity concerns. All right, so the chart that we had up above showed that margins are back up to where they were or better. Does that mean the rural hospital crisis is over? Joke I've been making is that when Lynyrd Skynyrd gives a concert, everyone just wants to hear Freebird. George and I have been playing Freebird at every concert that we've been giving and talking about rural hospital closures for, I think, the last 10 years or so. The chart on the bottom shows the annual number of rural hospital closures. We saw highest rates ever in 19 and then set again in 20. 20 was set off to even higher rates, but we really saw very few after May when the CARES money started to flow. But in 21 and 22, hardly any closures. So that's great. Project done or problem accomplished. Let's move on. You know, I think we've made the case here that we're very concerned about what happens as this CARES money has ceased to flow. Hospitals need to readjust to their reality of where they were back on February 28th, 2020. There's a North Carolina Health News study that's cited below there that basically says the same thing that we did in a brief we put out a couple months ago. That basically says, yes, if you're not careful and don't know what you're doing, margins look incredibly high now, but that's a false impression, and we really need to understand what's coming is probably going to be as bad as 19 and 20, if not worse. You know, has the CARES money hasn't solved the problems in rural healthcare that were in 19 and 20, and if nothing else, we know more about what's going on there. A couple other issues in terms of context to address and what's happening in rural hospitals in particular. We're seeing rural residents increasingly getting their inpatient care from urban hospitals. Work by two of our Ph.D. students. The first one there found that the average daily census at rural hospitals fell 13% from 11 to 17, but we really haven't seen this at urban hospitals. So the average rural hospital has a lower census than it did just 6 years prior. And there's many reasons that could be driving this. You know, there were hypotheses that we generated after that finding. It turns out that most of this is the increasing tendency of rural residents to seek care at urban hospitals. So this is not rural places getting smaller, rural places getting less inpatient care, rural residents. These are rural residents deciding, I'm not going to get my care from the rural hospital, I'm going to get it from the urban. And so what this has meant is, well, before I do the next chart, this is a game that I played growing up called Sorry. And if you remember this, if you land on the little triangle, you slide along the slider and you end up at the circle. And if there's someone, a different game piece on that area, then you bump them. So this goes from the triangle to the circle, right? And that's how you want to think of these plots. So these are sometimes called dumbbell plots, but I call these sorry graphs. You start at the green, you end up at the yellow. The green is the percent in 2011. The yellow is the percent in 2019. And what this shows is the trends in what percent of a hospital's revenue comes from outpatient business. And you can see, first off, that rural is much higher than urban. Those two dumbbells are centered around basically 70% for rural, closer to 50% for urban. Roughly half of rural hospitals get more than 3/4 of their revenue from the outpatient side, where that's about half of their revenue for urban hospitals. So a rural hospital needs, a typical rural hospital should spend less time worrying about their inpatient book of business than what's happening on the outpatient side. Their clinics, their emergency room, for example, would be a much larger portion of their revenue. Roughly comparable across the different census regions, a little higher in the Midwest and Northeast, and then different kinds of rural hospitals, critical access hospitals, sole community hospitals, Medicare dependent, rural and urban PPS, and then rural referral centers have slightly different patterns as there. CAHs with higher, urban PPS, as we saw in this chart above, lower. This was work done by a undergrad here at HPM. So we have this trend away from the inpatient side of business in rural hospitals. Another key development that's been happening is the systemization. I've heard different verbs try to be coined on this. Systematizing, I'm not sure, nothing really caught on for me yet. But the increasing percent of hospitals, and in this case, the revenue at those hospitals that are located in a hospital system or a healthcare system. So in black lines here are for urban hospitals, green are rural. What is the percent of revenue nationwide for hospitals with that rurality classification that are at hospitals that are part of a system versus those that are not? Urban went from 61% in 2011 to about 71%, an increase of about 10 percentage points in 10 years. When you look at rural, that's an increase of 15 percentage points. So rural is growing faster. And that 21 percentage point gap in 2011 is now 16 percentage points. So shrinking rurals are becoming increasingly part of a system. This is not happening equally across the country. And this is the region of the South as defined by the census. We can argue over whether West Virginia and Oklahoma is in the South, but the census says it is, so we're going to include it in there. These are ordered left to right based on the percent of rural hospitals revenue that was in a system in 2012. So whatever a rural Delaware hospital looks like, there was 0% of revenue in 2012 that were as part of a system there, 39% in 2021. So if you look at the difference between the green and the blue in any given state, though that's how much the systemization of that state in rural hospitals has increased in the intervening 9 years. So West Virginia went from 48 to 70, Oklahoma went from 51 to 72, North Carolina 59 to 75. So one of the three largest jumps, I guess barely edging out South Carolina. But note how many states really didn't change. Maryland saw a decrease, Kentucky about the same, Virginia, a smaller increase. So the trend towards rural hospitals becoming part of a system was faster in North Carolina, and look across the South, the only state that has a higher percent is Virginia. So what's behind that? Well, in this chart, I've taken the same sort of idea. Let's break the revenue at every hospital in North Carolina and put it into one of 6 buckets. Part of a system that's not UNC and not Vidant. The blue family, which is a Tar Heel blue for UNC Hospital and a dark kind of like Duke blue, I suppose, for community hospitals. Apologize to that, but I wanted 2 blue colors there. The purples are in the Vidant family, and I broke them out separately because PCMH was Pitt County Memorial was represented as not being part of a system in the early part, and so to keep it apples, I wanted to have it as a separate line. And then the gray are independent hospitals. So let's talk about this graph, what's going on here. Well, if we look at the green, really not much change in the percent of revenue that's in systems other than UNC and Vidant. About a 1.8 percentage point increase. On the other hand, the independent hospitals have fallen dramatically from almost 25% of revenue in 2011 to about 1/6 in 19 and 20. So about a 7-8 percentage point decline. And if you look at the UNC line more broadly, 3.1 in community plus 5.3 in UNC Hospital in 2011, that's 8.4% of North Carolina hospital revenue was in the UNC system in 2011 versus 13.6 in 2020. So most of that decline in that gray bar of the independent is really attributed to the growth in the UNC community hospitals, largely through merger, acquisition, affiliation, but the growth of the UNC health system, which is important context when you're talking about what's happening in our state. All right, so where does that leave us? So I've spent the last 20 minutes babbling about rural hospitals struggling financially and closing, a move towards an increasing reliance on outpatient business at the decline of inpatient care. And given this context, it sure would be great if someone acknowledges reality and said, what we really want to do is notice that when a rural hospital closes, the thing that people notice the fastest is the ED closure. Whenever you find a media story on a rural hospital closure, the lead paragraph is usually about someone who needed the ED, it was closed, and a poor health outcome happened. So what can we do to design a new type of provider that recognizes these trends and prioritizes the provision of ED care in a small community? And so with that, I kick to my good friend George, who will take us home with the second part of the slides.
Thank you, Mark. Thank you very much for asking us to present today. I'm going to start off by uttering two phrases which you do not often hear in the same sentence. I'm a professor, and I will be brief, because Mark and I want to hear what you think about this new model. Mark has done a great job of summarizing some of the big pressures that have resulted in this new model. The rural hospital closures that we've experienced over the last decade, a phenomenal decline in inpatient utilization, and a recognition that it's still important for rural communities to have access to good emergency care. So this new model is called the Rural Emergency Hospital. It has its origins in the Consolidated Appropriations Act of 2021. This is really big news in the Medicare community because it is the first new Medicare payment classification in 26 years. That was the last time Medicare added one. So it's getting a lot of attention. Essentially what this does is it proposes a new model of care, and I can't emphasize that enough because a lot of rural hospitals are I think, interpreting this as just a variation of an existing rural hospital, but it really is a new provider type that does not provide any inpatient care. It provides all full range of emergency department care, observation care. It relies on a large outpatient service, and it gives an optional SNF option as well. All the EMTALA, all the normal ED regulations that are applicable to any hospital still apply to REHs. CMS has recently issued the proposed conditions of participation for REHs. They came out in July. The public commentary period ended about a month ago, and so they are now considering the feedback they've had. But I'm just going to quickly go through what this model looks like in terms of what CMS has proposed the various conditions of participation to look like. So the staffing is going to be a more flexible model, a combination of various types of advanced practice providers. They will have medical staff privileges. They must have all the staff they need to meet regular emergency department care. There is a part of the commentary that CMS wants feedback about as to whether a practitioner must be on site at all times or whether they can be within a 15, 30-minute call, for example. They have to have staff with training in emergency call and immediately available all time. The proposed emergency services, they have to have 24-hour access. They must be staffed 24/7. However, again, whether a practitioner has to be physically present is not yet been determined, as long as it's a nurse who's there who can contact the practitioner. This is one of the things they want to debate about. They will be organized under the medical staff, and again, it will have to meet all the regular critical access hospital regulations regarding emergency services. These will have to provide, there's some mandatory services that legislation includes, and that is the laboratory, imaging, and pharmacy must be available for all patients who go into the REH, consistent with the kinds of level of services that virtually any emergency department in a community hospital would offer. There are some optional services that the legislation allows, outpatient services, and this is called optional, but really the model depends on substantial outpatient volume to make it to make it a financially viable model over the long run. I'll talk more about that in a second. One of the most contentious issues, or not kind of controversial, I guess is not contentious, controversial issues is whether REHs will allow labor and delivery. You know, what will happen when a mother is about to give, a woman is about to give birth, shows up in the emergency department. There will be opioid and behavioral health, but on an outpatient basis only. And then skilled nursing facility will be available. REHs will be able to apply for a SNF as a distinct part unit. The transfer and referral arrangements will be critical. They have to have a transfer agreement with a level 1, level 2 trauma facility. That is not optional. They can have transfer arrangements with other 3 and 4 trauma centers as well, but they have to have the 1 or 2. So this is as a finance professor, this is where my pulse rate increases. Basically the payment policies for this model were issued in July. The commentary period ended about a month ago, about 2 or 3 weeks ago. And I'm going to take this opportunity as a finance professor. I can't resist the opportunity to just go through some of the basic arithmetic that CMS used to come up with the payment. So essentially there are 2 components to the funding of the Medicare funding of this model. One is something called the monthly additional facility payment, which I'll go through in a second. And the second is enhanced reimbursement for outpatient services. So the monthly additional facility payment is an interesting beast. Essentially, this is based on the reimbursement that CMS pays to critical access hospitals. So critical access hospitals, for those who are not familiar with them, they receive cost-based reimbursement for Medicare patients. So what does that mean? It means, well, in a very simple analogy, if you have 100 patient days and 40 of them were for Medicare beneficiaries, then you would get 40% of your inpatient costs reimbursed to you as payment for the Medicare patients you have. So it has been a very successful rural model because it protects them against the ups and downs of revenue swings that comes from PPS. So what CMS did was essentially, I think the initial premise or the principle they had for devising this payment strategy was that REHs shouldn't cost anything more than what a PPS would pay. The different in terms in comparison to the critical access hospital. So what they did is they added up. Here's the total amount that CMS spent on critical access hospitals in 2019. That was $12.08 billion. That's how much money CMS paid to critical access hospitals across the country. They then went through a long estimation process. And when I say long, I mean, I think there's like 25 pages of explanation of how they did this. But they estimated what would the CEHs have been paid if they had been paid under prospective payment. And so they estimated that to be about $7.68 billion. So essentially the difference between those 2 numbers, the 4.4 billion, is what they say, that's what the critical access hospital system program cost the United States government, $4.4 billion. As of the end of 2019, there are 1,368 critical access hospitals. So that means that the average critical access hospital consumed $3.2 million of additional funding from the cost-based reimbursement. You divide that by 12, you get $268,294. That is the amount of the additional facility payment for every rural emergency hospital that will be approved in 2023. The additional funding, as I mentioned, the outpatient, anything billed using the OPPS schedule will be paid at OPPS rates plus 5%. And virtually every other service is paid just according to the normal fee schedule. So there's no other enhanced reimbursements besides the additional facility payment and the enhanced OPPS payment. It'll increase every year by the hospital market basket percentage increase. That has been concern expressed about that because under cost-based reimbursement, critical access hospitals are protected to the most part, for the most part, from inflationary pressures, because whatever they spend, they get some proportion of their expenses reimbursed by Medicare. Now they'll be into the same market basket increase as all other hospitals. There is no adjustment for volume of patients, case mix, or location. Again, this has been a criticism that we've heard as well. Other big questions: we do not know how Medicaid programs are going to pay for REH services. There's a lot of variation among states, and we expect that to continue among REHs. There's only 3 or 4 states so far that have actually passed licensure laws that will allow these types of facilities in their states. So there's still a lot of uncertainty with respect to Medicaid, and Medicaid is a big payer for rural patients. And then finally, capital. There is no mention of capital in legislation. Most of the consultants with whom we have talked, who run freestanding emergency departments in Texas and other states, will tell you that that the REHs, the building and equipment, may or may not be usable as an REH. The National Rural Health Association has put together a very thoughtful critique of this model. I'm not going to go through all this. Some of it is, I've already mentioned, they're concerned about the market basket increase. They want the 5% add-on applied to services other than just the OPPS schedule. They're optional. I won't go into some of the technicalities there. They want sequestration not to apply to the REH, again, to give the incentive for communities to adopt this model. I'm going to talk more about the 340B program in a second. And many of these facilities have got rural health clinics. Again, I won't go through the technicalities, but there was a grandfathering that happened 2 years ago, a year and a half ago. They want it to continue with REHs as well. We're about to issue a paper in about the next 2 weeks, actually, looking at entitled Key Considerations for a Rural Hospital. This is a non-trivial decision for a board, a community, and the board of a hospital. There are many different things to consider. Of course, I'm a finance professor, so I would always say it's got to be a financially viable model, or it won't be viable for the long run, then it's probably not going to be adopted. There are a lot of workforce issues involved. There's recruitment and retention of doctors and nurses in particular. Community issues, and I'll talk more about these in a second. The referral relationships, many EMS networks in rural areas are not well organized. They're going to have to get better organized in order to handle the transfer volume that's going to happen. And then some of the regulatory issues as well. So in summary, I think rural hospital closures are a problem. I think, as Mark very clearly pointed out, 140 of them have closed since January 2010. Patients are having to travel further distances to access care. In some cases, 5, 25, 30, 40 miles. And closures could resume, and I think we're already starting to see evidence of them, of closures starting. There's one happened yesterday, in fact. And so there's optimism, I think, that rural emergency hospitals may be a solution for some communities facing imminent closure of their hospital. This model is not designed for healthy, ongoing, viable critical access hospitals or small rural hospitals. It is designed for communities that face imminent or high risk of closure of the facility. So some of the strengths of the model that we've heard, it preserves access to emergency and outpatient services. As Mark said, the most common lament we hear from communities where the hospitals closed is the lack of emergency services. If you're having a stroke or a heart attack or about to give birth, traveling 5, 10, 15 miles could make a big difference in patient outcomes. Some people are arguing that stabilization and transfer to trauma centers could actually provide better care and outcomes because of the wider range of expertise and facilities. And finally, if you give a community the choice between closure and an REH, I think most communities would probably choose the REH. Some of the concerns we've heard, and we've heard a lot, probably heard more concerns than we have strengths, which isn't surprising, I guess. One, the long-term financial viability is unclear. The additional facility payment, the size of it was larger than many people were anticipating, so it's got more interest than perhaps was originally thought. However, this is really, aside from the facility payment and the enhanced OPPS reimbursement, this is essentially a fee-for-service model. So a lot of hospitals that are getting, critical access hospitals, are receiving cost-based reimbursement. Whether they will be willing to exchange that cost-based reimbursement for largely a fee-for-service model with the additional facility payment is uncertain and unknown. We're just going to have to wait and see. Secondly, again, we've heard this a lot from some of our consultants that we've talked to who do this for a living. The communities may resist the closure of the inpatient facility. A lot of communities pride themselves on having a hospital. It's a mark of civic pride. They may be very worried about the loss of employment at closure of the facility, because REHs almost certainly will have a much smaller staff than an inpatient facility. And then the bypass, they may just go around the REH. They may say, well, why do I want to go to the REH? I just drive another 5 miles, I'll go to the urban hospital, and then I don't have to be transferred. So those kinds of issues we've heard quite a bit. Third, the capital required. Many hospitals are hoping that they can use their existing building and equipment. That's from whom we have talked, many people with whom we have talked, that is a skeptical assumption. The layout, the patient flows of an REH are going to be very different than an inpatient facility. Some inpatient hospitals are hoping to convert a lot of the inpatient facilities to community-based services and consolidate community-based health services, practitioner offices, and so on. That might be viable. But there's going to be an issue about where they're going to get the capital from. Third, there's worry that the REHs may increase the difficulty. It's already incredibly difficult to recruit practitioners to many rural areas, that this may increase it because particularly physicians often need the inpatient practice to make a decent living financially. And so you're really asking practitioners to make a living out of an outpatient basis only, and that may make it more difficult to attract them. There's worry that large systems may see this as a cost-saving exercise that may not necessarily be in this community's best interest to have an REH, but it's a great way to save some money and reduce our losses. And then finally, there are some major flaws in the legislation. Some people believe there are some major flaws in legislation that will require congressional fixes. The first is that facilities that closed before 2020, so all those 140 hospitals that we talked about closing, none of them are eligible to apply for REH status. They're not allowed, they're already closed. Unless you were open on December 21st, 2021, you are not eligible to apply for an REH. And a lot of folks are saying that that needs to be rethought. Swing beds are not allowed. I've had many hospitals telling me we're not interested in this model because there are no other SNF beds in our community. Our critical access hospital is the only source of post-acute care. This model does not interest us. And finally, probably most important from a financial point of view, is that REHs are excluded by the legislation in participation by 340B. And a substantial proportion of critical access and other rural hospitals depend on 340B revenue they're financially dependent on that revenue. If you want more information, we published a brief last June that estimated the numbers of hospitals that might convert to this. The National Advisory Committee on Rural Health and Human Services that Mark is a member of, they published a very good brief as well a few months ago. We also have the next 2 weeks, we have 2 new briefs coming out. key considerations, which you saw the table for. And secondly, we're looking at some of the characteristics of small rural hospitals with very low volume emergency departments that may be interested in converting to the model as well. We're eager to hear your thoughts. I'll let you guess which one's me and which one's Mark. But we are really interested to hear what you think about this model. And we just want to close just mentioning that we have one of the best research teams in which I've ever been associated. These people are so committed to rural health and so smart. It makes Mark and me look really good because we're such a good team. So thank you very much for listening, everyone. And I'll start looking at some of the chat comments. And Mark, if you want to look at them as well.
George, Justin asked a question about how hard will it be for REHs to go back and convert to a hospital, I think is what I'm hearing. You know, is this the kind of thing that they try out the REH and say, oh, that was a terrible idea, and we want to switch back?
Yeah, that's another, there are many commentary, many issues have been raised by the public in the public commentary. That is one issue that they want clarification on. In the legislation, when I asked that question actually to a lawyer at a conference, and her response was, there is nothing in the legislation prohibiting return to PPS or return to CAH. That just basically says because there's nothing there, there's no reason you can't do it. But I think what the NRHA and others want is they want specific wording about the process that would be required to do that.
Yeah, George, there's a question from Jason. Jason, you want to unmute and ask your question?
This just isn't on the radar of many states yet. There's only 4 states that have actually passed legislation that will allow an REH. So it's, it wouldn't surprise me if they hadn't, but it wouldn't surprise me if they're starting to recognize it.
All right, Mark, you got your hand up. Mark Merrill, you have your hand up.
Yeah, thanks, Mark and George. That was an outstanding summary. I greatly appreciate it. And George, your summary of the risk and alternatives for critical access hospitals was right on target. I wish you'd been a consultant when I was still working. My last job was with Valley Health System, of which we had 4 critical access hospitals. And you're right about the greater challenges now with regard to staffing these facilities in order to maintain any type of inpatient capacity. We made a decision roughly 4 or 5 years ago before I retired that these are going to be primarily outpatient focused with robust emergency department, and then some stabilization for services that can be elective like general surgery and orthopedics, and maybe rotating specialists down who could then provide outpatient services, you know, ENT, plastic surgery, dermatology, neurology to build the outpatient. Because sustaining the inpatient enterprise means you have to have 24 coverage, you know, for general surgery, for anesthesia, and that just becomes increasingly challenging. But having rotating services from a tertiary center is what was helpful for us. Your comment also about the risk of eliminating 340B could be a nail in the coffin to some of these rural hospitals. So your summary and your pros and cons and risks were just outstanding. I commend both of you for that information. The last comment would be, having talked with colleagues, I'm hearing that 22 is the pressures are really rising because the CARES money is going away, and the labor rates in particular are escalating at significant levels, not just in nursing, but nursing and allied health becoming increasingly, you know, double-digit increases, and just an unsustainable revenue/expense forecast. So I was wondering if you had any more current information for what you're seeing in the first 6 months of 22. And I'll stop there. Thank you very much. Great job.
Well, I would agree. I think Mark and I have been inundated with emails of hospitals hemorrhaging money everywhere. You know, labor expenses are going up very quickly, particularly for nursing, and the CARES money was substantial. I mean, they literally in and of itself probably prevented many rural hospitals from closing. So I totally agree with everything he's saying. I think 2023 could be a challenging year.
Thanks. Christine?
Thanks. Hi, thank you so much for this. I'm a year one DRPH student, and I live in Vermont, part of a health network. So we have 6 hospitals. 2 of them are formerly critical access hospitals. One is in Malone, New York, which isn't technically a critical access hospital, but kind of should be. And we've looked at this. We do have Moses Ludington Hospital in New York was a full hospital, and then went to a freestanding ED with a primary care center attached to it. I'm wondering, I have 2 questions. One, on the 340B revenue, was that revenue included in that like 7 billion in that category? No, it wasn't. Okay. And then my other question is the dollars, that extra that few $100,000 per month that they would get. Are there any restrictions on how they use that?
The legislation states that when you apply to become an REH, you have to tell CMS what you're going to do with that money.
Okay.
And then CMS will literally approve that plan hospital by hospital.
Interesting.
So there's not a lot of guidance about what they have to use it for other than to maintain the infrastructure of the ED.
Okay, because I'm thinking primary care investment would be something that would need to really heavily accompany a community, which you also see. I also see that we have very difficult time maintaining primary care networks and infrastructure in these communities. So it would be interesting if it could be used to improve primary care.
Yeah, that's a very good point. And as the primary care is one major challenge facing these rural communities, there's probably about 25 other ones, including behavioral health. You walk into any rural hospital these days, you're going to find 5, 10 people on stretchers waiting for transfer to a psychiatric hospital, for example. Newborn obstetrics practices are closing in hospitals all over the country. What's going to happen when mothers are about to give birth when they show up in the area? There's a lot of issues to sort out. So
we just closed the OB-GYN service in Malone, and because of the birth rate going down and the demographic of that community, it was extremely difficult and very contentious in the community. It was tough. So I'm living all of what you're describing. I'm living it right now. So I so greatly appreciate everything you've shared.
Josh Horn?
Yeah, do you all think that these initiatives will influence or push the CON sections to rethink some of the hurdles that they put in place for this type of kind of critical or extended access, thinking about hub and spoke models and how they've influenced some of the systemness as well? Do you think it'll push them to change, especially thinking about North Carolina?
I'm going to punt that question to my colleague.
Yeah, I mean, CON is really complicated, and there's a lot of strong opinions on both sides. I think, yeah, I'm not, I don't know. How about that, Josh? I just don't know.
I just know some of the stuff they do with the capital requirements and whatnot. I mean, and even if I think, for example, if you had the ability for some of these folks that close these facilities and you still have maybe a very feasible facility available for something like this to immediately happen, just something from a CON requirement could put a hurdle in place that, could very heavily sway a decision.
Thanks, Josh. Trey?
Yeah, thanks, Jeffrey, and thanks to both of our presenters today. I am told to tell both of you hello from Bill Jolly, who is one of my colleagues in Tennessee. So I invited him to join me. He couldn't, but he sends his regards. My question is around something that we've recently seen in Tennessee that was announced this week. We had a critical access hospital actually convert to a behavioral health inpatient facility only in the Chattanooga market. It's part of a larger system, so it's a little bit easier than a county-owned or a standalone to kind of play that game of chess. But I was wondering, kind of one, if you see that being a continued trend, especially in the health system world, and two, if there are any kind of, for the hospitals that are not willing to make the jump to REH, if there are specific things like SNF and swing beds, like adding behavioral health inpatient services or taking them away. We do quite a bit of consulting on how do you toggle your service level up and down for financial viability. And I think as you all study multiple states, what are kind of the right mix of services? Is more always better, or do we see things that just create more financial unrest for some of our community hospitals and critical access hospitals?
I'll kind of address the first piece, and that is the link I just dropped in the chat is a link to our closure database that you can look at and see what these closures have become. Sometimes there are car washes or condos, but probably half the time they convert to an urgent care clinic or a specialty clinic or a behavioral health center. So I'm going from memory because it doesn't look like we have the behavioral health in the tableau. George, I want to say it's about 10% of closures convert to some sort of behavioral health clinic, but I don't know if you know. It's not many, but it's a couple.
Appreciate it, Mark.
Mark, there's a question for you from Jason about out-migration.
Yeah, I'd have to. Yeah, it's a great question, and I think we have done it, but I don't remember it off the top of my head. So I was gonna look into it and then drop an email if we know. But I think what Jason's asking is the notion of a rural hospital that is 10 miles from a 100-bed hospital, for example, versus the rural hospital that's 50 miles from a 100-bed hospital is going to face differing levels of competition. How about that? And what is the influence of that? I think that Jason, I think that's kind of what you're getting at, if I'm paraphrasing. Yeah.
Yeah, I think there's unique circumstances geographically in a state like North Carolina where we are, right, where you can be in a very rural county, but proximal to a much less rural county. I mean, you think about how populated a county like Johnston County has gotten in places just east of Wake County, but you go one more county over, right, and it gets much more rural. And so it's just a curious question to see what shows up in the data. And then you go to someplace like Montana and it's very rural, is really rural out there. Right? So. Well,
that you stole my response to that, which is rural North Carolina looks a lot different from rural Kansas. And I think there's a reason that so many of in the brief that George mentioned that we have published, he did work to look at what states would have the most, and Kansas, I think, had the most or was in the top two. And it's just a different level of rurality and isolation that's going to make REH more appealing in those kinds of environments.
The answer to James's question about equity, there is nothing to my knowledge, there's no incentives to improve health equity concerns in the reimbursement mechanism for REHs.
Yes,
maybe the last question too.
Sure. Yeah, your comment about behavioral changes in the rural community is particularly challenging, because having operated these 4 critical access hospitals, is we had to minimize some of the services to include OB, which the other lady was talking about. Many patients would say, I'm not going to drive 20 minutes to spend time in the emergency department and be shipped somewhere. I might as well go ahead and spend 30 minutes and drive, or 45 minutes to drive to the place where I'm going to end up. So trying to anticipate and communicate to the community what services they can depend upon to be there is a very important marketing communication strategy to the population that you serve, so they don't just bypass you and sort of accelerate the loss of volume to your particular facility.
All right, Mark and George, any closing remarks?
I appreciate the opportunity to talk about our work today. Thank you.
If you have any questions, I can give you George's cell phone. You can call him anytime you want, and he'll be happy to answer, especially at midnight.
Now you understand, the privilege I have of being able to work with these two gentlemen every day and the impressive work that they're doing. Thank you so much for engaging with us this afternoon, and be on the lookout for our announcement of the next webinar, Lunch and Learn series. We're hoping to maybe get one more done this semester.